We're very happy that you're here to join us today for the annual John E. Whitmore Memorial Lecture. This lectureship was established in 1987 by the late Clara Whitmore in memory of her husband, who served as a board member of the college as a perpetual tribute to his lifetime accomplishments. I actually sit in the Whitmore chair, who knew, and I had the wonderful opportunity to meet Clara before she passed away. It was my first month here. Really delightful woman who was thrilled that we were having this lecture series in honor of her husband, her late husband. Today's lecture is from Dr. Jeffrey Sachs, who serves as the director of the Earth Institute at Columbia University, an organization that brings together the people and tools needed to address some of the world's most difficult problems, from climate change and environmental degradation to poverty, disease, and the sustainable use of resources. He reminded all of our graduates about that last evening and charged them all to think of the planet as being slightly unhealthy at the moment and to fix it. He's also professor of sustainable development, professor of health policy and management at Columbia University, and the special advisor to the United Nations Secretary General on the Millennium Development Goals. He received his PhD from Harvard and is widely considered to be one of the world's leading experts on economic development in the fight against poverty. His work on ending poverty, hey John, hey Laura, nice to see you. His work on ending poverty, promoting economic growth, fighting hunger and disease, and promoting sustainable environmental practices has taken him to more than 125 countries with more than 90% of the world's population, and even to Texas. We count that as a separate country, by the way. For more than a quarter century, Dr. Sachs has advised dozens of heads of state and governments on economic strategies. He works closely with multiple international organizations, including the World Health Organization, the United Nations Development Program, the World Food Program, UNAIDS, and the Global Fund to Fight AIDS, TB, and Malaria. The recipient of many awards and honors, Dr. Sachs is a member of the Institute of Medicine, the American Academy of Arts and Sciences, the Harvard Society of Fellows, and the Fellows of the World Econometrics Society. He's also now an official MD from Baylor College of Medicine. That is his highest honor, for which he is forever grateful and treasures, or something to that effect. There really can be no greater advocate for the missions of education, research, and healthcare than today's speaker, who's regarded internationally as the voice of the poor. So please join me in welcoming Dr. Sachs.
Paul, thank you so much, and ladies and gentlemen, thank you for the enormous honor and pleasure of being with you. That medical degree, believe me, that is cherished, and I got it the easy way, of course. I know the difference, and I'm really grateful to all of you, and grateful to this profession, as I think the whole world is for all that you do. And I want to talk about the profession in the context of the global health challenge. This is an important opportunity and moment for us in global health, medicine, public health challenges, because we're in the context of negotiating now a new framework for world development at the United Nations. And while sometimes that news doesn't resonate too far in our own country, it's actually very important for the world. And it's made a big difference for the world in the last 14 years. We've had a process called the Millennium Development Goals. A number of you are world leaders in that. I've worked especially closely with Peter Hotez, the Dean of the School of Tropical Medicine at Baylor College of Medicine. And the Millennium Development Goals, I think it's fair to say, have been a very good lever for our activities, because global challenges found a place to advocate, a pedestal, an opportunity to help educate world leaders about challenges and about how health is not only an end in itself, perhaps the highest end according to most people. When they ask what's important for you, they say health. But also it is essential for everything else we want to accomplish in society, including economic development. And so the Millennium Development Goals were an important way to help make that idea also part of the discussion and aims and organization of international development activities. Well, those Millennium Development Goals were set for a 15-year period, and they're coming to an end at the end of 2015. And starting in 2012, because it takes the world a bit of time to discuss these things, the 193 member states of the UN have been debating and negotiating and analyzing what should come after 2015. So in a way, my talk is about that. They set the idea of having a new set of goals called Sustainable Development Goals, or SDGs, to follow the Millennium Development Goals, or MDGs. So we're in the transition from MDGs to SDGs, role in that. And that's really the backdrop of what I want to discuss today, and stop with enough time to have a good discussion, because there are a lot of very, very knowledgeable and thoughtful people in this room. So what's interesting from a social and advocacy and moral point of view is that health has been regarded as a basic human right since that concept first came to the fore in 1948 with the Universal Declaration of Human Rights. You remember Eleanor Roosevelt was absolutely essential for that crucial document, and it's made a very big difference in giving an idea in all parts of the world, no matter what kind of government people have, that human rights are important. They reside in individuals, and they include not only political and civil rights, but also economic, social, and cultural rights. And that among those rights is the right to the maximum attainable health. And this was established already in 1948. It doesn't mean that those rights are observed, we know. It means that we need to aim towards their realization. And like many good things in life, and many moral ideas, even if they're not realized, they still are beacons for us, and they still can make an important difference in the world. When the Universal Declaration of Human Rights was actually, the World Health Organization was constituted. And the Constitution of WHO also set health as a basic human right. And both those documents, the WHO Constitution and the Universal Declaration of Human Rights, makes clear that what it means is that the access to health services, health care, is independent of class, race, gender, being a minority or a minority group in a society. That's at least our human aspiration, though of course it is not realized in the world. We've made a little bit of progress in recent years. In 1978, many of you will know or have studied, there was an attempt, one of the most important attempts, to operationalize this universal health goal in what was then called the Alma-Ata Declaration, and now that place is Almaty in Kazakhstan. And the World Health Organization Assembly, the world's ministers of health, came together in 1978 and declared a practical goal of health for all by the year 2000. And they did something important, I think, practically at that time, not only the idea that one could look at health in a programmatic global way, in other words, set a date, a timeline, a goal, but they also put primary health care at the center of this and talked about the idea that everybody should have access to primary health services locally, in their villages, in their towns, in the cities. And the effort was at least conceived that there would be a scale-up of primary health services all over the world to realize that universal right to health. It didn't happen. Not only did it not happen, the 80s and the 90s were actually a very difficult period for economic development globally. A debt crisis in Latin America, some of you will recall, broke out in 1982. Mexico defaulted on its debt. Argentina, Brazil, everybody else then quickly defaulted on debts. This spread to much of Africa and Asia. The period that followed macroeconomically was a very difficult, contentious, tough period called the structural adjustment era. And the IMF and the World Bank became kind of policemen at the time for debt collection. It was my own formative years in economics. I had my fun battling with the IMF for many, many years because I said you can't really cripple the poorest countries by demanding debt repayments when they can't even meet basic needs. The fact is that during that period, healthcare suffered a lot. And there was an idea that was also extant at the time. It's still part of our own ethos and debate very much that healthcare should be privatized, and that was carried to even the poorest places in the world. And fee-for-service, privatization, and other means were also implemented in the context of trying to collect service on public debt. One other horrific thing, of course, occurred. It was occurring but not yet recognized until 1983, really, or 81 to 83, and that was that a new epidemic, the HIV/AIDS epidemic, was taking off. It's a little shocking to realize that millions and millions of Africans were already infected and dying of AIDS before it was even recognized as a disease when patients in California were first diagnosed and the virus was identified soon afterwards. And after it was identified, it was gradually realized that the epicenter wasn't San Francisco, it wasn't Haiti, it was Southern Africa. And as the epidemiology was worked out, it was realized that not only is this not exactly a new disease, although it's a newly recognized one, it had probably been transmitted in Africa since the 1920s, according to the genetic clock of looking at the transition from simian immunodeficiency virus to HIV, human immunodeficiency virus. But also there were already probably 15 or 20 million Africans infected. And then there was one more damn thing that was a reality by the year 2000, which is that this overall fading of focus on health of the poorest that came in the context of the 80s and 90s had also left open a massive crisis of drug loss of drug efficacy as there was a loss of efficacy of first-line malaria meds to resistance of the parasite, and also the discovery and realization of the spread of drug-resistant MDR-TB, multi-drug-resistant TB, and then extreme multi-drug-resistant TB. All of this meant that we reached 2000 in really quite a state of affairs, not health for all by the year 2000, but multiple mass epidemics, AIDS, TB, malaria, collapsing health systems, collapsing life expectancy, especially in Southern Africa, where life expectancy fell from the early 60s down to 35 or 40 because of the AIDS epidemic. And it was a little bit in that context that I arrived at this, because I'm a macroeconomist. I'm not a public health specialist by my original training. As I mentioned last night, I did the best thing possible. I married a doctor, so I had entree into the field, but I did not work on these issues until the mid-1990s, and I started going to Africa for regular finance work. And the thing that was the most overwhelming reality for me was how many people were dying around me. I had never experienced anything like it in my life. I had worked in very poor countries in Latin America. I had worked in India. I had worked in China. I had worked throughout Southeast Asia. I had not worked in Sub-Saharan Africa, and I arrived in Sub-Saharan Africa in 1995, and literally the first words of my team leader in a finance ministry project, not a health project, but a finance ministry project, is that 8 of our 30 professional counterparts had died recently of AIDS. It was something that was so far out of my experience and sense of reality. I was completely shocked by it, and then even more shocked by the fact that they had died without any medical treatment at all. I said, "What do you mean they died?" "Well, they had gone back to their villages to die." "What do you mean they had gone back to their villages? Why hadn't they gone to a hospital?" "Oh, Jeff, here you don't go to the hospital with AIDS, or you don't go to a doctor, you go home to die." It was just a death sentence. And then I came to realize also, since I was quite naive about these things, that everybody I turned to had just had malaria, or their children had malaria, or they were home because their wife was sick with malaria. And also, to me, that was quite strange, because I thought that was a disease from the early 20th century American South and the marshes of Rome that had kind of been eliminated in most places by the 1950s and 60s. Of course, what you know, and I hadn't fully realized, is that what had been called the Global Eradication Program for malaria actually did succeed in eliminating malaria in the subtropical and temperate zones, where the force of infection was low enough that modest interventions, DDT spraying or other modest interventions, were enough to reduce the basic reproduction number of the disease to less than 1, in other words, to break the transmission. But in the hard tropics, where malaria is endemic, and especially in tropical Africa, where it's holoendemic and where infection rates can be more than 50% year-round in typical rural villages in Ghana or Senegal or in other highly malarious regions, there had been not only no end to the disease, not even a break in transmission, there had been a collapse of funding, of coverage, and chloroquine, which was the medicine of choice for decades, was no longer efficacious. And so the disease was massively spreading. And I also sense that, not as an epidemiologist, but just as a human being walking around and dealing with people in Africa for the first time. And again, I found 2 things as a pre-specialist in this area. And it also took me a little bit of time to unravel. And now I'll come to the positive point of the story soon. Nobody was spending any money on any of this. The total spending on AIDS worldwide in developing countries by donor governments and international organizations at the end of the 1990s was under $100 million. It was about $70 million. The only thing that the Western world was doing, including the United States, the World Bank, and others, was giving speeches. If hand-wringing could be turned into money, there was wealth galore. There was lots of hand-wringing, but no programs, no efforts. And interestingly, though antiretrovirals had been around since the early 90s and combination therapy since around 1996, as of 2000, indeed, till the end of 2001, there was not one African out of the 20+ million infected that was on antiretrovirals with official government support from any Western country. Not one individual, because there were no programs at all. Millions and millions of people were being left to die. So that was the prelude to this new period. And at that point, I was pulled into this story because I wrote a paper on malaria and economic development, which showed that wherever malaria was endemic, poverty was deeply persistent. And after trying as best as possible to control for other determinants of economic development, malaria just stood out as a major independent causal factor. And that result has been now sustained in many kinds of research projects, from local to global study, that malaria is a major direct contributor to impoverishment in places where malaria is heavily transmitted. And so on the basis of that and a couple of cri de coeur that I made at the end of the 1990s, are we really not going to spend any money on millions of people dying? Gro Harlem Brundtland, who was then head of the World Health Organization, asked me to head a commission on, which we called the Commission on Macroeconomics and Health. And she said something quite interesting to me. She said, you know, Jeff, I had been a prime minister of Norway. She's a great woman, by the way, you know, absolutely phenomenally great leader of our time, and brought sustainable development and a lot of public health innovations and a lot of human decency to the world in the last 40 years of her leadership. She said to me in 1999, when she asked me to head this commission, she said she learned as prime minister, it didn't matter at all what a prime minister believes if the finance minister believes something different. So she said, could you please bring health ministers and finance ministers together so that they could talk with each other and understand that investing in health is not just a pain in the neck, it's actually also a solution to economic development. So the year 2000, 2001 turned out to be a fruitful period. Our commission, which was a wonderful opportunity, had the likes of Manmohan Singh, who went on to become Prime Minister of India, who could then implement some of these ideas. And Harold Varmus was a great help, and Gro Harlem Brundtland and many others. And we recommended, after looking at the data, a massive scaling up of development aid as a way to address some of these challenges. We said health is not only a high return target of investment, but it's a very practical target of investment as well. If you put resources into public health, you get something out at the other end. And that's because you know what you're doing. And the health field has protocols and methods and ways to turn resources into health outcomes. And so we made that case, and simultaneously, Kofi Annan, who had become Secretary General of the UN, brought the issue to the global community, and I worked closely with him, and we recommended establishing a fund, a global fund, to fight AIDS, TB, and malaria as a way to channel these resources. And lo and behold, I was delighted that Texas's own George W. Bush turned out to be a great hero of this as well, which was a little of a surprise to me, frankly. Speaking freely, I didn't anticipate it, and that's also worth just a mention, more than a mention, just an explanation of politics. President Clinton did nothing on this issue except wonderful speeches, but they did nothing for global health, nothing. The time came and went, and it was lost. And since then, he's worked in his foundation a lot on this, but as president, nothing. And early in 2001, because I was in the midst of all of this, I went to the White House to see Condoleezza Rice, who was the National Security Advisor. And she gave me a full 2 hours with the whole national security leadership to discuss AIDS and what could be done about it. And I made a pitch that we should have a $3 billion a year program to fight global AIDS. And I came twice, because she came 1 week and then she asked me to come back for further briefing. And at the end of the second week, I was led out of the White House by a former student of mine, Larry Lindsay, and he put his arm around me. He said, "Jeff, those were wonderful briefings, but you don't stand a chance. There's no way we're going to be spending $3 billion a year on AIDS globally." And I said, "Well, it's really important, Larry." He said, "Nice try. Thank you." Chance. It turned out it happened exactly. Watching the twists and turns of it was very interesting. Tony Fauci played a huge role from NIH because Dr. Fauci was the person that George Bush really believed in to give him the very straight story, and Tony became a great champion of what became PEPFAR, which is the President's emergency program on AIDS. And the second route to this was also very interesting and worth, I think, understanding, just taking a moment to understand. I was driving home one day in 2002, which was a year and a half later from those meetings, because nothing had happened yet, except that President Bush had quickly joined the U.S. into the new global fund that Kofi Annan and I and a few others had helped to get started. And so some resources started to go into that. And then the next year I was driving home at Harvard, and I can remember the call to this moment because I got a call on the phone, and I was driving home, and, "Hello, Jeff, what are you doing?" "It's Bono." I said, "Oh, Bono, good, how are you?" He said, "What are you doing?" I said, "I'm driving home." He said, "I think you better pull over." So I did, and pulled into a little parking lot that I remember to this moment. I said, "Bono, what's up?" He said, "Jesse Helms just blessed me." I said, "Oh, good. What happened?" He said, "Well, he was just crying on my shoulder. We had read scriptures together, and he said, 'I want to bless your work on AIDS,' because Bono and I were together trying to advocate for all of this." Jesse Helms called the White House, said, "Take care of that young man," not me, Bono. He's doing the Lord's work. And it turned out that really the religious community in the United States played a huge role. Franklin Graham, Jesse Helms, many others, and that's how PEPFAR, in my estimation, got started. That you had Tony Fauci coming in from one side, you had the religious constituency on another side. It was really a marriage of medicine and a moral outlook. And President Bush announced this in early 2003, that the U.S. would scale up tremendously its contribution to AIDS. And 2 years later, after I badgered the White House for a long time on that one, they announced also a scaling up of malaria control. So the backdrop is that 2000 became a kind of watershed after a disastrous 20 years. And just about that time, Peter Hotez called me, I think around 1999, and we sat in a cafe, I remember that also, across the street from the Kennedy School, and he gave me my opening education into lovely things like Ascaris and Trichuris and other helminthic infections and other lovelies that he specializes in, and explained to me that there was a cluster of neglected diseases, and AIDS, TB, and malaria were worthy, but don't forget the following list of awful things that people are suffering and dying from. And of course, Peter did really path-breaking epidemiological work, as well as many other kinds of path-breaking work, in showing how high the burden of disease is of the helminthic infections, leishmaniasis, filariasis, now dengue, Chagas, and many other tropical diseases that weren't in the headlines at the time, but also to an important extent are first comorbid with the headline diseases, second, maybe major risk factors for those other diseases, and three, can also be treated effectively in many cases, or at least prevented for the vector-borne diseases and so forth through vector control and often also effective treatment if made on time. And so that was another important salient that got started, which was to bring the tropical diseases to the forefront, and nobody's done more than Peter Hotez in that. And I think we should give him an applause for that also. So what do we know of what's happened since the year 2000? Let me start with a picture which I like a lot, which is just a scatter plot of life expectancy by income. So life expectancy is on the vertical axis and income is on the horizontal axis. And of course, there's an increasing relationship. And it's an increasing relationship with a strong decreasing marginal product of income, meaning that for high levels of income, you don't gain that much more in life expectancy for incremental average income. But at low levels of income, this curve is remarkably steep. And that is, for me, the starting point. That's great news. If the curve didn't look like this, if the curve were basically a linear curve, you'd say, God, there's nothing really you can do fundamentally until you develop. If the curve were, instead of being a concave curve, if it were a convex curve where you had to have high income level till you got the big gains, then it would be even worse. You'd just be condemned to bad health for the whole period of that long stretch of economic development. But when I looked at that curve and also tried to reason out what it means and what its implications are, it suggested to me a different story, which is that all the gains are at very low income, aside, by the way, from these five outlier countries, four shown here, which are the AIDS epidemic countries of Southern Africa, the true global epicenter of the AIDS disaster. But putting AIDS aside, this increasing relationship is all at very low income levels. That means that one gains 20, 30 years of life expectancy for small incremental gains of average income. Now, most of that gain of average income, that's annual income in the population, isn't directed to health per se. And so the amount of increment of really health-related outlays that are leading to this big increment of life expectancy is really very small. And that suggests something quite interesting, which is that maybe if we target small investments to very poor people in the right kinds of ways, one could have a very, very big effect on life expectancy, child survival, and health. And that's not such a strange idea because we know that many of the causes of death, in fact, most of the causes of death of poor people in poor countries, and I should put it more precisely, most of the causes of excess mortality of low-income countries are conditions that are either easily prevented through measures like immunization, or can be treated at very low cost, or can be prevented through access to interventions such as preventing mothers from dying in childbirth by availability of emergency obstetrical care. And so this curve suggested to me from the very beginning, and it's a point that I've been trying to demonstrate and advocate for, that what we really have is a situation where millions and millions of people die every year of conditions that could be prevented at extraordinarily low cost, and that it should be possible to help devise those health for all interventions that could dramatically improve health at what in the United States we would regard as shockingly small sums of money. And that's what I take to be a hypothesis at least raised by this kind of evidence. And since 2000, we've been trying to put that to the test. It's not perfect because the amount of development aid available for this has gone up, but not as smoothly and as broadly and to the extent that's really needed. But still, there's some important lessons. So the backdrop of this, one area where that huge variation of life expectancy arises, of course, is in the first 5 years of life. The Underfive mortality rate differences account for the vast amount of the differences of lifetime life expectancy at birth. And so it's children dying before their 5th birthday. And of that, a huge proportion die before their 1st birthday. And of that, a huge proportion die in the first 28 days of life in infancy, in the neonatal period. And the question is whether one can direct resources effectively to prevent those deaths. So to give you some metric, in 1990, the estimate is that about 12.6 million children died before their 5th birthday. As of 2000, that had come down to about 9.7 million, still a startlingly large number. And of that, in the developing regions, it's 130,000. So of the 9.7 million in the year 2000, 130,000 were in the high-income countries, the US, Europe, Japan, and so forth. All the rest were in the developing regions. And of course, the two regions of greatest vulnerability are Sub-Saharan Africa, the #1 region of excess disease burden in the world, and second, South Asia, India, Pakistan, Bangladesh is the other overwhelming site. Since then, the numbers have come down proportionately much faster to 6.5 million. So over the period from 1990 to 2012, there's been a reduction of roughly half. It's about a 48% reduction. But you can see here, if you can see the numbers from the back, that the mortality rates per 1,000 live births still remain startlingly high in Sub-Saharan Africa, around 100 per 1,000 live births, 1 out of 10 children not making it to the 5th birthday. And in South Asia, it's 60 per 1,000 roughly, 6 out of 1,000, 60 out of 1,000 not making it to the 5th birthday, 6 out of 100. So we have these two epicenters that remain. And here is just a color-coded map that emphasizes it's tropical Africa and it's South Asia, where the vast bulk of the high child mortality rates remain. The question is whether it's really possible to intervene in what is a vicious circle or a kind of trap of poverty and ill health through effective health interventions. Clearly, poverty is one of the main, if not the main, risk factor for premature mortality. And the point that I was emphasizing is that disease burden is a major risk factor for poverty. If children are unhealthy, if they can't get to school, if they lose cognitive development, if they lose physiological development, if their parents are sick or dying of AIDS, if millions of children are orphaned from AIDS, if communities are down with the malaria at the time of harvest, which is very frequent because it follows the rainy season by 3 months, so the larvae are out and the mosquitoes are biting and the disease is being transmitted, then of course that's also devastating. So you have an obvious two-way causation, and two-way causation leads to vicious circles, but also the opportunity for virtuous circles. In other words, the question is, can one invest not in ending poverty directly necessarily, which could be more resources overall, but invest in disease control, not only to improve health, but also to help break the vicious circle. And I will just go quickly. Actually, I just want to say one word about malaria, a disease I've come to love to hate, and love to fight. And Peter's maps of many other diseases show similar patterns. There are such strong geographical correlates of many of these diseases that you realize that, of course, people are often blamed for circumstances that are ecological and way beyond their control. And when it comes to malaria, we know that that's a tropical disease because the life cycle of the Plasmodium depends on, especially inside the mosquito, that 2-week period called the sporogony, depends on the ambient air. And if the temperatures are roughly less than 18 degrees centigrade, the mosquito dies before it becomes infective after taking a bite of an infected person and not yet biting the person to whom it's going to transmit the malaria. So you need warm air to make the mosquito, to make the life cycle transformation of the Plasmodium fast enough to be within the short lifespan of the mosquito so that the mosquito is infective. Turns out that, so that means that this is inherently a tropical or subtropical disease. And it's much more powerfully transmitted in warmer climates. And this is, of course, thoroughly demonstrated and known for almost 100 years. It's also the case that there are different kinds of Anopheles mosquitoes which transmit the disease. And the really hard, sad reality for Africa is Africa has the worst of them. It has exactly the kind of Anopheles that only bite humans. And that's a bad thing to live with. Because if you live with Anopheles that bite cattle, that breaks the human-to-human transmission chain. Whereas if you live with Anopheles gambiae and funestus and arabiensis, which only bite humans, then you're guaranteed essentially that every 2 consecutive bites of a mosquito are human bites. And this means that the force of infection in Africa of malaria is just out of control compared to any other part of the world. And there's a genetic marker of that, of course, that proves the point, which is that sickle cell and other hemoglobin anomalies are vastly higher in proportion. The alleles of sickle cell can reach 10 or 20% of a West African population. And that's because of basic Hardy-Weinberg principles that malaria was so key to the mortality burden in that region that it allowed that partial protection and partial devastating allele to take hold in the population. The point I'm making is that Africa has it the worst ecologically, not because it doesn't care, not because it's not trying, not because it's badly governed, all the things that are often said, but because it lives with Anopheles gambiae strictu sensu. That's a horrible place to live. We won't want our children living in such places if there isn't malaria, if there isn't effective control alongside it. So as I came in as a rank amateur in this, but had my quick education during the last 15 years from Peter and from my wife and from Harold Varmus and from many other experts, I came as an economist to really admire the public health logic and approach to this as a kind of management discipline that is exactly the kind of rigorous discipline that's needed to turn scarce development assistance funds into real results. And I regard the public health discipline or public health philosophy, if I can call it that, as exactly the prototype of how development aid should be used. I'm an advocate of aid in a country that doesn't like it very much in general, and I am constantly arguing day in, day out for the last 15 years that aid can work. And I'm misunderstood as arguing that aid does work. Those are two different things. I'm arguing that aid can work. And I'm saying it can work if it's evidence-based, science-based, and systematically applied. And when I designed the basic design features of the Global Fund in the first draft, I tried to put those design features in, that this should be a professionally run organization, not a politically run organization, so that we could get the best of public health. So what is the best of public health in this regard? Start with the epidemiology. What are the diseases you're fighting? What is their burden? Second, of course, what are the interventions that are effective, especially the low-cost interventions? Third, how do you design delivery systems? These are places without doctors. These are places without clinics. These are places where traditionally people walk 10 or 20 kilometers, often with a highly febrile child in their arms, often arriving at a clinic with the child dead in the mother's arms. Because there's no transport, often you'd get to a laboratory, there'd be no reagents, no microscope, no microscopist present to read a blood smear and so forth. In other words, these are deeply resource-deprived environments. So the question is, how do you design effective interventions that can work? And a lot of that, and a lot of what we've been working on for the last 15 years, is how do you get community-based delivery systems? How do you use high school graduates who are trained to do a rapid diagnostic test of malaria and then to prescribe a malaria medicine? How do you back them up with a smartphone system? How do you enable supervision at a distance for a relatively low-trained worker, but who can make a life and death difference with oral rehydration, or with reminding a mother to go to an antenatal visit, or with observing therapy for TB, or observing taking antiretrovirals, or prescribing an antibiotic for a pneumonia infection under guidance of an expert system or of a doctor 20 or 30 miles away. So this is the design problem that's crucial. It's not to invent hospitals, it's to invent how to operate in low-resource rural areas, not to forget the hospital at the end of the chain, but to have supervision systems and mechanisms. And the beauty of what's happened in the last 15 years is that from zero phones and almost complete isolation, we now have ubiquitous mobile communications, and that's also a godsend for everything one wants to do for local healthcare delivery. So then an economist can come in on some of this management planning. What does it cost? How do you do the protocols on investment training, empowering and informing communities, oversight management systems, monitoring and evaluation tools? One of the things that we're implementing intensively is a verbal autopsy system, so that all deaths in villages can be monitored. An ostensible cause of death, at least roughly, can be determined, of course, with huge error bars around it, but that there can be some kind of feedback in real time to what's happening in terms of the local health management. So the claim that I made and our commission made back in 2000, put into today's dollars, was something rather stunning. Not yet fully proved, and the numbers may be off by a factor of 2, but the claim is that for as low as $60 per capita, one can dramatically reduce the mortality rates down by, even today, after a cut of a half, down by another factor 4. So I would argue that with a reliable $60 to $100 per capita, now I'm moving the goalposts a little bit, but I'd take the bet at 60, but I wouldn't mind having 100, given what we've seen. You could get the Underfive mortality rates down from 100 to 20 per thousand. For $100 per capita, I think it's a safe bet. I've been trying to engage Bill Gates in that bet for the last 2 years, and I'm still working on it, because he said yes twice and then his team said no twice. I said, take any district you want, any place in the world, and we'll use these methods, these low-cost methods, to get there. The fact of the matter is we're seeing in what we call the Millennium Villages Project, which my wife Sonia and I and hundreds of colleagues around Africa have been implementing in 10 countries. We believe when the evaluation is categorically done next year, but from the monthly data we collect, that the under 5 mortality rate is already 30 or below in almost all of the sites in places that started at about 150. Because causes of death were vaccine preventable, were lack of any basic neonatal knowledge at all, even the most basic resuscitation techniques, even keeping newborns warm, even helping with dehydration in the first days of life, helping to get mothers breastfeeding early on because of cultural concerns about colostrum and other cultural practices, and malaria control. Those measures have led to an incredible drop of the disease burden. And this is an investment that has come in the places we're working from the donor resources at a cost of about $40 per person, and from the added resources of government, I would say something like $20 per person. And we will do a full costing by the end of the project. Now, mind you, in the United States, we're spending $8,000 per person per year right now. So this is the difference of and I know that I'm in the world's largest medical center and the highest tech medical center in the world, and I'm sure happy you're here for all of us. But what it does mean is we have another opportunity that is still not fully recognized and exploited, and that is to save millions and millions of people every year, hundreds of thousands of mothers who will otherwise die in childbirth, and millions of kids who are dying for absolutely absurd reasons in the sense of the availability of an 80-cent dose of artemisinin combination drugs for malaria, or a $5 bed net, which it took me 8 years to try to, and finally to convince the international system, just give bed nets away to poor people. Stop trying to sell them, but just give them away. You can save a lot of lives. And finally, 300 million bed nets were distributed at the end of the last decade. And the malaria burden overall, in our villages, I think it's probably down by 80 or 90% in most places. And overall in Africa, malaria deaths are down by 50% now compared to the peak in 2004. And simple action of having 3 things: artemisinin drugs available, second, having bed nets. That's the next line of medicine after chloroquine. Having bed nets freely available, and increasingly having community health workers who are empowered to deliver rapid diagnostics locally in the villages, and then to prescribe these medicines in the case of a positive reading of the RDTs. This is already saving hundreds of thousands of lives per year. So let me end by, actually I'll just recount one more story. When I first started myself in this area in the late 1990s, I went to another wonderful dean of School of Public Health, Barry Bloom, at the Harvard School of Public Health. And I said, Barry, can you suggest to me a textbook for how to treat AIDS in low-income settings? And he looked at me and said, what do you mean? I said, well, can you give me a textbook, because I'm really interested. I'm seeing a lot of it. He said, a textbook on treating AIDS in that doesn't exist. And I said, what do you mean it doesn't exist? He said, well, there isn't anything like that. And it was, another step of my realization that there was no treatment going on still, which was a point I was trying to grapple with. Even till today, though, we don't have the kind of field and textbooks of how to treat X in low-income settings and how to find the most cost-effective ways. Now, I'm not a huge fan of cost-effectiveness because that often says it's not worth it to save those people. I don't mean to use the term in that context. I mean how to develop systems in which low levels of resources can do wonderful things. This by itself should be a major field of study and a major field of concern. Think of the problem that we have as we go into the 2015 agenda. 2015, next year, will adopt universal health care as a headline. So we'll move from the MDG's focus on child mortality, maternal mortality, and infectious disease control to a broader rubric, universal health access. And this is almost surely what the governments will adopt as a goal. And I think that it behooves us, and it's a great opportunity, it's a wonderful mission for students, it's a wonderful mission for the great universities in this area, and it's a wonderful way also to combine management, information systems, public health, and medicine to ask a very specific question. We have 6.5 million kids dying every year before they're under the age of 5, to put it simply. And almost all of those deaths are preventable. Almost all of them could be stopped by very low-cost interventions. But to do that requires systems. And it's a matter of designing the systems, mobilizing the resources, following through with the information and the feedback and the training, and getting the job done. I think it's an exciting prospect. We can already see that we're making progress. I think for the new grads that are in this room, I would urge you to go for it, at least in part of your time, because we should aim that by the year 2030, those excess deaths have been eliminated entirely, and that finally, before a full century is out from the Universal Declaration of Human Rights, we have met fully the right to health. Thank you very much.